no preferred pronoun. Congratulations on making it this far. Let's have a great round. I would like my panelists to introduce themselves in an alphabetical order. So, Oarben, Ram, Sam, and Sophie, go ahead.
Hi everyone, my name is Oarben. Congrats on making this far. Yeah, and good luck.
Hi, I'm Ram. Good luck.
Hi, I'm Sam. Good luck.
Hi, I'm Sophie. Good luck.
Perfect. So, I think we're good to go. Just a couple of reminders that I'll time you, but I won't be sending stamps so I can focus on doing what I have to do. And reminder regarding the POI rule. With that said, I'd like to call on the Honorable Prime Minister to open the debate in their name. Hear, hear.
Hi, sorry. Am I audible?
Yes.
Thank you.
Oh, let's wait a bit. Someone is joining pa.
Okay, sure.
From opposition. Okay, all good. So you may
Okay.
begin whenever ready.
Okay. I'll take PYs through chat, just like in my preferences. Okay. Starting my speech in 3, 2. Opposition's world is one where they gatekeep healthcare. It is one where people allow their sicknesses to get worse to the point of near death. It is when they fail to get a bed in ICU care because people are just too overcapacitated and overworked. What we uniquely explain on our side is why we solve these issues and why general hospitals are the way to go if you want an increased intense amount of access, but also to stop and prevent diseases from getting worse. 2 points of setup. 1, what does the rise specifically look like? And this is where I want to clear up the margins of the debate. This isn't about private sector investment. These things are undetermined by the debate and uncertain and determining where you can put these things in the first place. What this likely looks like is the government funding. It looks like the Philippine Heart Center that is currently funded only by the government. That means that it's about the allocation of where this money goes. Secondly, what they have to support on their side is the increased number of specialty hospitals being set up. The problem is that general hospitals are lacking in specialty equipment. That is, they are outsourced to these specialty hospitals. Things like bypass surgery, things like endocrine cleaning, or also specialists themselves. It looks like maybe Toby's dad, who's the only bone doctor in Baguio, that importantly mean things like inaccessibility to these equipment, but also the scarce nature of these resources. But secondly, that it's often exclusivity contracts that specialty hospitals induce in order to protect themselves from outside competition. They do things like by paying extra money for patent distribution of this technology so that this technology cannot be distributed to different hospitals. What this explains uniquely is just why you can't have both on their side, but secondly, why you're never able to spread these things towards general hospitals because of the model. What we prefer then on a comparative. 1, it's general hospitals having some level of specialized equipment. Why is this likely? 1, its funding for specialized equipment often comes from rich donors that would be given to the general hospitals, otherwise when special hospitals just aren't in the rise. Secondly, that distribution is no longer limited. This is fairly intuitive. Lastly, that you compete on quality for patients, and so there's a necessary incentive for you to invest in these things in the first place. What is the importance? The importance of this is that the incentive increases for things like early diagnosis and preventative measures because you're not certain that there's another hospital to fall back on when you need to do things like bypass surgery. It's that most people's needs aren't bypass surgeons in the first place that uniquely explain why we solve that on our side and why it's important. First argument, how have specialty centers harmed systemic access to proper healthcare in the Philippines? 1, it's why the rise the first thing I want to question is why the rise has pulled support from general hospitals in terms of funding and capacity. There's 2 reasons for this. 1 is that you take specialized doctors from them. It's that you pull physicians doing triage or consultations into a field that they're not aware of. And the reason why you're likely to do this on their opposition side is because of the shortage of these people. It takes intense amount of time to specialize in medicine to get into medicine in the first place. And at that point, it's exactly why you just settle for terrible people under their model. Secondly, it's that you reallocate government funding to specialization centers. And there are 2 reasons why it is the case. One, it's often just far easier for governments to put these things as electoral incentives for people to vote for them, as glamour projects that give them a better reputation, and that's why they reallocate significant amounts of funding into specialty centers rather than general hospitals where most people enter. But secondly, that it's a preference, that maybe cancer patients want these things, that maybe the most vulnerable individuals want these things to some extent. And that's why governments appeal to this type of emotion by investing heavily into specialty centers rather than general hospitals. Second thing, what then is the problem? I want to note the problem is that they don't solve the needs of society. There's three main ways they don't do this. One, it's often early diagnosis that is the pervasive problem in developing countries. It is that you are unsure if a sickness is going to extend from tuberculosis into an inherent lung problem like popcorn lungs. Or maybe it's that you're unable to decide whether or not the pain in your chest is something that will extend towards needing heart surgery and bypass surgery. The importance of this is because of the lack of preventative diagnoses and early diagnoses within general hospitals because you underfund them, is that you're unable to stop any meaningful means of these illnesses just getting worse on their opposition side. But secondly, often it's small diseases that we need to prevent in order for these things like big medicine to be important in the first place. Lastly, that it's also just opt-in, that people just can't access health checkups. They just can't access inherent medicine. And what governments do when they specialize in specifically specialty centers is they lessen the capacity for people to access medicine in the first place that allows for them to access health checkups, that allows for them to enter and opt into general hospitals, that is just terrible for them because you remove their agency to get healthcare from the get-go. Lastly, that on the worst case, even if maybe accessibility is better than our side, why is our side still better? One, it's government funding and strategy is just much more like, it's something you get more investment in. That is, you cater to more people. You make more bang for your buck because a lot more people opt into general hospitals in the first place, and that's why you want to benefit them. Secondly, that it's not just a problem of price that you put only it's not just a problem of price with specialty centers. And the reason why you only put a couple of them in a country is specifically because the barriers to setting them up, I'll take you later, are just so high. You have to hire specialists. You have to hire equipment. You have a small capacity to do these things in the first place. And the specific nature and inherence of specialty like centers is that they aren't likely to do things like increase their hospital beds just because they aren't willing or understanding that maybe more people will enter onto their hospitals and opt in. Lastly, it's often just that common problems like tuberculosis are just the biggest killer. It's not big diseases that we can solve on general hospitals. It's that you need to solve things like tuberculosis, things like pneumonia, often things that spiral into these terrible things that exist on opposition side that necessitate specialty centers in the first place. I'll take a POI.
So you can see that there's a shortage of specialty doctors, denoting that there's probably an urgency that needs to be catered to on your side, but you don't even provide any analysis or a solution as to how you cater to this shortage in the first place.
No. The problem that exists in status quo is you invest a lot of your money into special hospitals. And under the thing, right, it's that you have these things are somewhat government like general hospitals in the first place. The problem is that you saturate these hospitals because most hospitals just offload all of their patients into these areas just because they're underfunded. They don't have enough doctors. They don't have enough bed capacity. They don't even have the specialists needed in order to give you things like x-ray diagnoses and whatnot. And that's the problem. You centralize all these things into singular hospitals that overwork people to a mass extent, but also make it harder for people to access meaningful healthcare under your side. Second argument, why do we solve this problem on a comparative? The first is a focus on prevention, that you know that you have a lack of equipment as a general hospital, and that's why you focus directly on preventing diseases. You give more checkups, you give easier medicines, you give things like painkillers and whatnot to make it sure that you have preventative interventions to make sure people feel at the very least healthy. Secondly, there's a larger spread of talent, that more talent is spread out and you don't centralize these things only to specialty centers. And the reason for this is obviously specialty centers need to monopolize this power, and that's why they pay people highly. That's why they pay people extra amount so they can monopolize all of these specialists into their hospital. That's terrible because the benefits are monopolized. There are often state regulations to benefit them and help them to do these things. But lastly, there is no incentive for spread of talent across the country. The importance of this is that you don't lessen overcrowding. You don't lessen overwork. Lastly, when general hospitals fail, it's just that you have more accountability. You can call these people out because you aren't dependent on specialty hospitals to offload this work. All of these reasons clearly win Gov.
Thank you for that speech, calling on the leader of the opposition to open the case for side negative. Hear, hear.
Sorry, natutuwa ako sa intro. POIs through voice. I'll type it in chat. Through voice. I typed it in chat. You don't type it in chat. So you tell me to voice. Okay.
Okay.
My grandmother is alive because of the health center in the Philippines. I'm happy she's alive because finally she got the care that she wasn't able to access all the years before the health center arrived. But I guess government just wants my grandmother to die. So the first thing I'm gonna do is agree extraneous rebuttals. Number one, the very uncharitable mechanism coming from government is that there are explicit contracts not to compete. First response is that there are patents usually expire. So this means that this is just a breathing pain for usual things, for these things to be accessed. Under our paradigm, sure, there's a profit incentive to do certain types of medicine or certain technology in the first 5 years to be able to be not to be accessed so that people can profit off of it. But patents expire so that the rest of society can access it eventually. The second thing is that usually government funds usually provide legislative injunctions to prevent these patents from happening in the first place if these are important types of medicine or technology towards the status quo. So this response removes the uncharitable framing coming from government that it's not going to be accessible. First argument, why do we think this is principally just? Before I argue this, the first thing I'd like to frame is the fact that general hospitals still exist under our side for the simple fact that the rest of history of only known general hospitals, the fact that we have two here in Manila, I don't actually know how many because I don't live here, but in Baguio, there are two general hospitals that exist there. We tell you that these things are enough for the simple reason that we've invested for them historically already, and they're already probably set budgets for these as well, which means that under their paradigm, they can't say that suddenly all of the general hospitals are just going to explode when we have new specific hospitals. This is absurd. But the second piece of response here is simply that you only need one specialized hospital under our side for the simple reason that you only need one mechanism for the 5 people who need it under our paradigm for the simple reason that this is simply easier to do for if you have one health center in Manila, everybody goes to Manila to be able to access it versus no health center at all means that under our side at the very least you get access. Why is it principally just? Government is going to say that on scale there are a lot more people who need that kind of money to be able to put into general hospitals versus our side where there's 5 people. The problem is that there are already capacity to benefit for a lot of these people for the simple fact that general hospitals supply general things. That means that there's already solutions in status quo to be able to prevent those things or to be able to help them. But the problem is that under status quo, there are a lot of people who don't have solutions to their problems who necessarily need this type of things. So even if they are a small minority, for the simple fact that they are a minority and they're extremely vulnerable, is a simple reason that they should be prioritized, and that's why this is justified. Second argument, why do we think the rise was necessary? We think that this is a failure of the general hospitals in the first place. Note that Asians are more likely to get insulin spikes and therefore diabetes because we live in a country that specifically eats rice, and rice is probably the main cause of diabetes under this paradigm, which means that in developing countries, they specifically have needs that are specifically centered towards their physiology and specifically towards their environment. The problem on the government side is that big buildings have very nurses spread too thin with a lack of facilities, and many do not get proper healthcare. Why is this exacerbated under their side when they regret the rise? Number one, general hospitals have generally high turnover rates, which means that people with specific needs are given general solutions. Look, for example, like Zen literally said, just give them like painkillers for their cancer. Like I just think that this is absurd, which means that you cannot buy it under their side. For the simple fact as well that they only have general medicine means that you do not get to access the benefits or the specific types of medicine that these people need, and therefore these people have higher mortality rates absent the rise of like specialization centers for the simple fact that under their side they misdiagnose them. The second diagnosis under why government side is harmful is because absent specialty centers, general centers are going to have lack of a diagnostic capacity. They usually gloss over special cases because most people go through the ER, and ER, where a lot of people go through, means that these people are not given the proper types of attention and care that they should have been given. But thirdly, having specialized doctors in general centers means that these are people who are spread too thin under their side because the endocrinologist is probably going to be faded as fuck because they have to nurse sick kids. I'll take the POI.
So why is it that these people from disadvantaged communities can access specialized hospitals, which, as you say, only have are only one in, for example, an entire region?
I think the reason is because you said that the government funds them, but I think the second reason is under your side, if there's no specialized hospital, edi saan sila pupunta? So the reason why under our paradigm it's significantly better because the rise came out of a need. The rise came out of people's clamoring that it's not enough for us to just get ibuprofen for our cancer. They told us that we need more specialized hospital because there are significant amounts of people who need heart treatment and is currently not given treatment right now because we aren't able to leapfrog those types of technologies or access those technologies in the status quo because the general hospitals just don't have the capacity. We only need one or two to replace like one general hospital. That is the extent, and government cannot misconstrue this forever what gaslighting they will tell you for the next 3 speakers they have. Second argument, why do we think the rise is inherently good for healthcare system? The problem is that these are developing countries where people are insanely poor and healthcare is insanely shit. Why is the rise inherently good? Number one, note that the info slide says that these are specific diseases. Note that diseases like antibiotic resistance and, for example, a lot of communicable diseases are specifically needed like specialized centers so that we can prevent those types of diseases in the first place. Under their paradigm, if all you have are general disease centers, then obviously what's likely to happen is under their side, COVID-2 is going to happen because under their paradigm, we weren't able to prevent these things because we didn't have the specialization to be able to prevent like patient zero, or for example, the type of like specialization to cure at least 50 of them, which means that under their side, the next pandemic is more likely to happen. But the second reason is because the access to leapfrogging is significantly easier under our side. When there's one center who can maintain all of these types of technology and all of these types of medicine, we tell you that development and innovation is significantly better when people get to focus on one thing rather than get to spread out. But thirdly, if there is a shortage, as Zen says, then we tell you that the rise meant that there is significantly more demand for it. In fact, we tell you that if there is a center now, we can train more people within those centers so that there's more people doing these things in the first place. Again, all of the harms coming from government are birthing harms. But finally, for the simple fact that needs of people change, like for example, in the future, we might have even more specialized problems and specialized treatments that we need to provide people, but general hospitals generally cannot provide it, which means that the rise of specialty centers are the only solution to be able to provide the types of need that people could access but currently can't, because the only infrastructure that developing countries have are specifically just general health centers. What is the conclusion to this speech? Number one, we tell you that one is enough. If you only need, like the rise includes just one specialty center in these countries, you don't have to put 100. That's not what we're supporting. Usually one is enough. Number two, we tell you that there are nuanced needs, like for example, the lack of diagnostic capacity, which people gloss over and therefore increases the mortality rates. Number three, we told you about the urgency of people dying from specific illnesses that might be communicable and is harmful for the general public, because if you do not prevent these things, that is significantly harmful to your economy and your interest as a nation. But finally, this is something that is inherently good for the minority of people who are vulnerable. For years, they have not access like the types of healthcare for their hearts, but now that they can, we think that is automatically a win, regardless of the birthing harms. We're willing to trade that off if at least my grandmother can live one more day. Proud to oppose.
Thank you for that speech calling on DPM to forward the case for side government. Hear, hear.
Yep, give me a sec. Okay, for POIs, kindly POI me via chat, and I'll make sure to take you. Three, two, one. JP Leong, the father of the first Philippine world champion, Toby Leong, is the only bone surgeon in the Cordillera Administrative Region, specialized to deal with osteoporosis. For 20 long years, he had to toil with waking up at 4 a.m., journeying through dangerous ravines in the mountains of Kalinga and Mountain Province to be able to cater to patients who are too weak to make the journey to the bone center in Manila. I'm very happy for Haduka's family that his grandmother is alive. But because his family had the money to go down from Baguio, had the resources, had the transportation to go to the heart center or the lung center in QC, what this means is that side negative banks on a privilege to help these same Filipinos that they want to help, who oftentimes don't have the access, who oftentimes don't have the privilege to be able to get the benefits that they suggest from side negative. This is an extremely uncharitable and privileged framing we get from side opposition. It's quite disastrous. Because the true state of healthcare in developing states, and side negatives make it worse,
when they continue to entrench people with the same privilege and money to access the best specialty centers in these urban areas, bankrolled by taxpayer money. Look at their own framing. They said, one specialty center is enough. If you buy that to be true from Haduka's speech, that necessarily means that people who have problems all the way from Region 1 or Soxargen or BARMM would have to go all the way to urban centers, either in Manila, Cebu, or Davao, just to be able to help. That's something regrettable and something we never stand for. First, I want to clarify the model because LO bastardizes this. Second, let's respond to his key win conditions on why it's far worse in terms of the healthcare system on their side. Lastly, an extension as to why research becomes much better on our side, winning a independent argument. Firstly, let's clarify the inherent characterizations of how the model operates in either world. Why can we improve the healthcare situation on our side? We were very clear. General hospitals have some specialized talent under our side of the house. We agree. It won't be as much as putting 20 heart doctors, for example, but at least one heart doctor in a general hospital is enough. We told you why this is good for 3 structural reasons. One, because oftentimes this allows you to have some baseline prevention, for example. So, for example, you as a general hospital would focus more on prevention to make sure that your clients or your customers don't necessarily reach to the extent of having tuberculosis or necessarily needing a heart bypass surgery. Second, we told you why talent is more likely to be spread, meaning instead of all the heart doctors in the Philippines conglomerating in Metro Manila, you have more heart doctors going to different regions like Region 5, Region 6, Region 7. But lastly, also, you get more accountability for general hospitals because they're forced to take care of you because they can't say, we'll just offshore you towards Manila, for example, and that's how they get away with responsibility because oftentimes you as the client don't have the resources to make that journey. So here's the clincher, right? We won't have heart doctors can solve every heart disease in every general hospital, but at least we make sure that the talent isn't wholly centralized to one center. That's how we're able to prevent more diseases. That's how we're necessarily able to help more people in terms of weighing. Second, let's respond to their initial frame. They claim that this is just a birthing pain. No, because that's not how this debate operates. This is a regret motion. So by the way, opposition, this already happened. And in retrospect, this is harmful for the healthcare system. So they can say, it'll happen in the future anyway. It's something we can support right now because these are birthing pains. No, because this already happened. So this frame is untrue. Second, their first win condition was to suggest that they cater to the most vulnerable. I think that this is just untrue, right? If you buy their frame to be true, you have one specialty center in every region that's being charitable. Because by the way, Haduka just said one for the entire country or state. That necessarily means that people from far-flung regions would still have to travel tons of miles. I don't think that's necessarily helping them. But also the second thing is that they said, it's going to be free or it's more accessible because the government necessarily funds it. Like this is incredibly uncharitable, panel. Obviously, if the government can fund every person that needs heart bypass surgery right now by going to the heart center in QC, then we wouldn't be having individuals with heart problems right now because governments will be able to fund them to the degree. But that's just unrealistic in how, firstly, the developing states operate, but also secondly, in debate land as well. Thirdly, they said, you have high turnover. This is the primary harm. So we respond to this harm, most of their claims fall. Firstly, we did not say that there's less turnover under our side of the house. But what we suggested is that turnover is worse under opposition. Because now you have people strapped with specialists who always go towards the big urban centers. What this means is that you just have less staff on net in general hospitals in rural provinces. What this means is not you have more people who have to do double tasks, for example, like what's suggested in the first info slide actually, where you have medical interns who are too overboggled with work because you have a shortage of full-time employees. That harm becomes worse under the side of opposition. Lastly, they say they can train more people. One, I think it's just unrealistic given training takes a huge amount of time for you to specialize in heart bypass surgery, for example, or treating osteoporosis. You take 5 years, for example, for your MD, you take another 5 years for your specialization. That's too much time. We at least want to make sure that we can spread out our talent right now in the best way possible. That proves why, firstly, in terms of vulnerability, they make individuals much more vulnerable on their side because they give them some option on our side. Second, they make it harder for individuals to be able to access some level of treatment on their side, and they also make it worse. POI.
Yeah, sorry, under your side, it's also extremely uncharitable to say that every general hospital will be equipped with some sort of heart equipment fixing thing. Like under your side, you have to trade off the fact that these specializations cannot work or cannot exist in the first place because you don't have that type of doctor and resource.
Yeah, bro, we traded that off from Zen. You weren't listening. We said not every hospital will be able to do the best bypass surgery. Maybe not every hospital will be able to treat you of osteoporosis. At the very least, we give you a couple of key mechanisms that are able to do already something. Firstly, you are able to detect the treatment, which is important for research and my extension, necessarily because most groundbreaking problems are oftentimes undetected because people are unwilling to go to hospitals to begin with. We lower that barrier to entry when we incentivize people to go to hospitals because now they know there's some specialists specialist who understands your problem. But second is that even if we can't treat you right now within the hospital, we at least take note of your disease, for example, and are likely to get back to you in the future. But my extension will talk about why research for specific diseases gets better under our side. And this is the reason as to why this debate winning. Because even if you consolidate all the specialists that are under one roof under their side, it's much better in terms of the quality of research you get under our side. Firstly, because a lot of the groundbreaking research, for example, on problems like pneumonia, for example, or malaria, oftentimes come in mutations from far-flung provinces, because oftentimes these are unmonitored provinces. People don't go to the hospital. The problem is that most of the novel problems come from marginal communities that never go towards hospitals. That's why you had a resurgence in polio in Soxargen, for example, or the H1N1 disease developing in Cagayan Valley. The reason why that's important is because when we lower the barrier to entry for people to want to go to a hospital, that's where we get earlier detection, for example, which is also good for the vast majority of the country, because now you're able to notify different health agencies like the DOH, for example, or the FDA in different regions, and therefore coordinate much better. This extension is debate winning, because this proves that even if you get the best specialized research under their side in the best case, you aren't able to track every new mutation. We are better able to do that even in the worst case, where we aren't able to solve your problem. We get better tracking, we get better long-term solutions.
Thank you for that speech, calling on DLO to forward the case for side negative here.
Okay. Hello. Oh, are we gonna do did you do the background? No. Okay, it's okay.
Sorry. Pwede naman.
It's okay, it's okay. I'll just get my timer. POS your voice. Okay. Starting my speech in 3, 2, 1, go. This is my personal thank you for your service, Toby Leong's father. But the rise is exactly the trend that will allow less burden on this man. Because notice that all of the problems are literally solved by the fact that this is a trend in rising amount of specialty centers. So for the incentive for more people to go into the industry in the first place and to create less burden on this man for oversaturation of patients, or for burdening himself for being the only doctor in Baguio, for example, is the only way that we are able to mitigate when we allow this rise to happen in the first place. We think that we have to clean up the debate by clarifying what each side stance really is before we actually move on to issues and integrating all of my responses and my extensions. Because government tries to argue that general hospitals are more necessary than specialized centers, but they also concede that there's a lot of specialized sicknesses or illnesses that exist in the first place. So the prerequisite for them to be able to be credited with this argument is that 1, specialized illnesses are not an urgent matter at this point in time, but 2, that general illnesses make up most of the concern of these citizens in developing countries. I want to say that the opposition's path to victory is a lot more simplistic comparatively, because 1, we say that the specialized illnesses will exist regardless, and the existing general hospitals are insufficient in being able to address these things. Therefore, the rise allowing more options, more accessibility, and more competition for these things to be opt-inable is what allowed a lot of these oversaturations within general hospitals to be moved towards these specialty centers instead. So we think that a lot of the reasons why they say that there's shortages or there's a lot of workload on these hospitals in the first place only comes from the fact that we're able to mitigate it when we allow more of these establishments to occur in the first place. So therefore, that is my first clarification within this debate. The two other issues that I'm going to be talking about is why exactly, 1, these specialized illnesses are extremely urgent for these developing countries, and why the insufficiency of general hospitals don't necessarily address them. 1, I want to talk about why people get sick, because I don't think that the whole idea, we are able to have preventative diagnosis on their side, is something that's plausible, given that the context that these are developing countries. I will talk to you why there's more erogenous factors as to why poor people usually go to hospitals when it's severe already. 3 reasons. 1, any day out of work is less income. Obviously, intuitively, you are not going to get or skip work at the point at which you can likely get a payday or salary at the end of the day. Second, your schedule is filled to the brim because day offs are not approved within the day that you just want to be able to get a day off and get a checkup. But lastly, because developing countries have resilience porn, oftentimes they have grind culture, you just are not allowed to be able to go to the doctor at the end of the day. This means that you usually get these people to lead to severe illnesses before they actually get to diagnose themselves or go go to hospitals in the first place. But it's also going to be exacerbated at the point at which your conditions are likely to be bad. So that means that there's also even more incentive for these illnesses to become even more specialized over time, because two reasons. One, you have bad working conditions. Obviously, you live in a place of pollution and just in general like climate change. But secondly, like these people have likely hereditary illnesses due to genetics. This is something that's passed down because of your bad working conditions. So it means that all of this issue means that when people get sick, there is an urgency for specialty centers specifically, because they are when these are special illnesses go very, very severe. So that means that for kidneys, for livers, oftentimes these people are going to hospitals when it's already extremely to the like fourth, fifth stage of when it's so severe, of when it's so like magnitudely harmful for the person. So why is it that general hospitals are insufficient in addressing this certain controversy? There's many people that get sick that's existed on both sides, but there will always be specialized illnesses and general illnesses. Obviously, on both sides, because general hospitals exist, both sides can still cater to general illnesses. It's more of where we're able to address these specialized illnesses specifically, because the government in general, like the state, allocates budgets per hospital. You have a set amount of funds, and we agree because they concede that specialized units will exist but are qualitatively worse. So therefore, why do we say that this trade-off is worse on their side? 3 reasons. One, because when you're in a general hospital and you allow your specialized units to be only considerably like concentrated within these general hospitals, you have more of an incentive to discharge them. Because when you're oversaturated with a lot of patients, because you're catering generalized and specialized illnesses, that probably means that you only have a limited amount of hospital beds, a limited amount of like dialysis, like machinery or whatever. Like all of these things are going to say like, oh, that you're not going to be the priority at oftentimes when there's a lot of people going in and coming out. That also means that on their side, when they say that, oh, if we can't resolve this right now, we'll just bring them back later on. Like what? Like in 10 years? Like we don't understand what they understand the wait list of these hospitals in the first place. The second is your capacity to treat extensively is heavily minimized. So if you're in your 4th stage or 5th stage of cancer, you will not get any palliative care because you're not in the priority list of getting that palliative care or that hospital bed or that IV fluid drip. Because at the point at which there are other more urgent people or like this dying from general illnesses, your special illnesses do not have the capacity to be treated or to be addressed, resolved, or in so far as you're not able to actually like go to them in the first place because nurses are going in and out in other hospital rooms. The last thing is the quality is divided throughout the hospital. So that means that even if you have a kidney unit or a liver unit or a specific specialized unit within your hospital, all of them are divided within your budget of the hospital, which we already argue is not enough because you already see that these types of people are already like cutting down healthcare costs in terms of government officials. So that means that it's even lesser pools of money at the point at which you're able to like resolve these things in the first place. But sure, POI.
You have yet to prove the prerequisite mechanism to believing people go to hospitals. Why are specialized centers accessible if there's only one in every state or country, as your LO claims?
Okay, so here is the solution, the solvency. The RISE specifically solves 3 things. The accessibility point is that because the RISE allows for more of these things to actually establish themselves, competition will likely let prices go down and make it more accessible to the average person. Obviously, the engagement coming from Haduka is specifically that 0 to 1 is still a better comparative than 0 on your side. So even to that extent, our best case is that obviously there will be competition, that a lot of these specialty centers will exist, but even to the worst extent, there's only one, that's still a net good compared to the comparative of known specialty centers on your side. The second thing is quality. Because you are more able to compensate these workers, the quality of your treatment and the quality of your palliative care likely for these specialized illnesses are much better off. So definitely in terms of like healthcare and like the principle of having you be able to the Hippocratic oath of making sure people live are just generally more abided by in our side. The last thing is you also just get more generally you just get more research under our side. When you allow specific centers to be towards specific like illnesses, you get better chances of making these like pharmaceutical drugs cheaper in the long run when you're ensuring that the incentive for them to be invested in is a lot more visible. A lot of these things mean that these metrics are that if you get a lot of more choices in under our side, you just get more accessibility as well. But at the point at which we prove to you that the quality of healthcare is much better on our side, that proves that you have to side with opposition. Thanks.
Thank you for that speech calling on Government Whip to forward the case for said government. Hear, hear.
Oh, that's so fine. Hi, am I audible and visible?
Can you try saying something just to make doubly sure?
This house regrets the rise of specialty centers in developing countries.
Yeah, Gucci, all good.
Okay, thank you. I'll just move you closer in case it becomes a problem. I'll take PYs in the chat, please. My grandfather is currently admitted into home care, slowly waiting to die, because when he was diagnosed in a general hospital with 2 rare cancers, they said something. They said that we cannot do anything for you because the new hospital built in Forbes took all of the autoimmune specialists away. This is not just my story or my family's. This story applies to thousands of people that now realize that the only way they can get healthcare is by putting themselves into debt, because the only way that they can get specialists, the only way you can get attention is to go to Manila and therefore afford these specialty healthcares. They want to talk about the vulnerable individuals. At no point do they talk about why it's particularly accessible to them. The first thing I want to say is that they needed to support the rise. One hospital is not enough. And if they see that there's that much demand, then obviously that one hospital would be overcrowded. They have to support a significant rise for any of their impacts to materialize. You can't buy the soft stance from first speaker. But the second thing I want to point out is at no point do they prove why it's accessible, aside from the new mechanisms at deputy that I'll deal with later. We give you mechanisms like how, for example, it's expensive. There are logistical strains that are inherent to these types of things because they're located in one particular location. The most important thing here is that they gatekeep healthcare from the most vulnerable. Their only response to this when we raised via POI is to say that the state will subsidize it. Like the state will block exclusivity contracts or the state will suddenly pay for everyone's healthcare. The first thing I want to point out is why would people do this? Like specialty centers look better for governments because they can paint it as glamorous products. So I'm just unsure, and they use it to hide, for example, the dire situation of overcrowded general hospitals. So I'm just unsure as to why governments would do this. But even if that's true, that's good for us. Why? Because if the government has that much money, that much time to train specialists on a whim, then presumably we can get it under our side and put it in general hospitals instead. That disproves their accessibility point. The first thing I want to prove here is what is the most important value in this debate, and I want to kick out their principle. We framed you very specifically. It's the context of developing countries. Listen, as much as we want a perfect healthcare system, we will never get it. You have to make a trade-off with public funding because you have limited funds in the first place. We argue something very simple. We cater to more people, right? So on scale, it is, for example, arbitrary to decide which suffering is more severe. It is more important than to utilize the limited resources you have to alleviate the most amount of suffering across a varied group of people. What do they say? They say you are neglected and therefore you are vulnerable. Here's the kicker. Everyone in the public hospital is to some extent neglected and vulnerable. They have to wait hours for checkups, etc., especially on their side where you take far more of their staff away. Public hospitals are also, for example, unsafe. You have high infection rates, etc. What does this all prove? It proves that if their only standard for where you're more important is because you're being harmed right now and therefore you are vulnerable, I'm sorry, that applies to everyone in developing countries. But secondly, as a state, I argue you don't have special obligation to those with rare diseases. What you do have an obligation, though, is the vast majority of your taxpayers, which are, by the way, the most amount of people that are likely to get sick. You only attain that standard of scale under our side. Then they say we have high mortality, high turnover. This all compounds worse under their side. And here's the flip. Why? Because you get far more staff that is overworking. You get far more overcapacity. That means it's not just especially people with special diseases who are misdiagnosed. It is the average person now who is misdiagnosed because they didn't have a physician on hand. They have to rush through triage because they're overcrowded as a hospital. That's the flip. You expose more people to vulnerability under their side. But the last important clarification I want to make is, what if you have someone with a special disease that cannot go to a specialized center? They don't have the time or luxury to travel to Manila, etc. These are the most vulnerable people. You leave them in general hospitals where there's no one to take care of them. At the very least, you give them one doctor that can at least give them some medicine to alleviate their pain. You get none of that under their side. The last thing I want to clarify under this issue is, what are we actually fighting for? Listen, it's maybe cancer is terrible, but it isn't the biggest killer right now. The biggest killer among developing countries is things like tuberculosis, and we solve that. And it's also, for example, the resource trade-off we highlight. In order to fund that one specialized center, you get 15 general hospitals because you have funding that is cut. You have less public opt-in, as we described that first speaker, and that's why all of these are worse. The second thing I want to deal with then is the rise. And this is like their kumbaya. Like they say, everything will be solved once there's a rise. Let's deal with all of these points one by one. I'll take a PY right now, by the way, if there's any. Okay, let's talk about their material. They say one, if there's a rise, therefore there's demand, therefore quality gets better. The second thing they say is that the rise is just a birthing pain, it won't last for a long time. The first thing I want to clarify is they cannot just use this analysis. Like, we give you reasons as to why structurally it's likely to be harmful. They can't just say it's just birthing pains. Like, they have to prove as to why it's unlikely to be a continuous problem. But the second thing, and this, but the more important thing is that it's untrue that you're just able to catch up to demand. Like, if there's a shortage, it is likely to continue for a very, very long time because it's incredibly hard to, for example, get a medical license. What you'd probably do right now is only in effect in 8 years, the moment that people graduate. So I'm just unsure as to why you're able to solve it. But on this mechanism of demand, I think it's just untrue. Like, for a couple of reasons. These specialized centers, one, have high base fees. So even if you have competition, it is still likely to be inaccessible for the average person. Like, obviously, you cannot go beyond your profit line or beyond your profit margin. So at best, you'd maybe make it a bit cheaper under their side, but it's still not accessible for the vulnerable individuals that they want to champion. But the second thing is that you make general hospitals worse. And I keep saying this again and again, but that's because it's really important. You take more people away if there is competition, because now you're paying for anyone who has a good medical degree from any of the big four to go to these specialized centers. So that means that all of the public hospitals then, the ones who are originally not part at all of the debate, are now suddenly pulled in, and all of people are taken because, for example, these specialized centers, because of the rich donors, etc., can offer better compensation. What about those people in public hospitals? They have no solvency for that. But the last is, on the point of a lack of turnover, the important thing here is that we mechanize down the bench, that you can't just transfer skills immediately, right? And the more important thing here is that even if you have that skill turnover, it's far better under our side because you have that, for example, chief surgeon that is able to talk to a lot of people and therefore get a lot of disease, solve a lot of special diseases. The third thing is on why it's an only solution. Okay, yes. But I will pause. I just want to say they only raised it twice and I did offer time. So it's not mandatory, but for the sake of charity, I will take it. But yes, so outside 601.
Yeah.
Go ahead.
This is an uncharitable frame that the rise can't amount to any like adjustments. Obviously, the rise will have incentives for people to care about it and therefore invest in it and therefore make it better. You can't just say it's not true and then suddenly it's not true.
No. Even if they do invest in it, you can't make it cheaper than the already expensive specialists that you have to pay as a base fee, regardless of how many people come in. You can't, for example, make it lower than the amount of specialized equipment that you have. And there's no way for you to disperse those costs or trickle it down to make it far more accessible. At least in a general hospital, we are able to do that. That's the mechanism I gave. The last thing they say is that it's the only solution. And the extension we hear from DLO is that it just gets far, far worse. The first thing is that we are able to detect these things first, by the way, if you have better treatment in general hospitals. Because no one just goes straight to specialized centers, as they say. Oftentimes, you go to general hospitals first. So if you fix that problem that we illustrate on how it's overcrowded, that is logically prior to any mechanism that they give. But the second thing is, again, they're just unresponsive to a lot of mechanisms. Like, we get specialized departments already in general hospitals. So I'm just unsure as to why this is likely to be a concern in the first place. I also want to flag, I just reached 7, so it's not 7:15. But yeah, so thanks for the proud to propose.
Thank you for that speech, calling on opposition whip to forward the case for side opposition. Hear, hear.
Hello, am I audible?
Can you just say something to make doubly sure, please?
I love debating. It makes my weekend so happy and so great.
Yay.
Audible and visible.
Okay. Oh, caught on recording. Everyone's gonna think I'm a nerd because I am. All right. Verbal POIs, just raise it once to make it fun. Turn on your camera. Yeah, great. I'll be starting my speech. And 3, 2, 1, go. On government, you can detect when someone has a severe sickness, but at no point are they able to treat it because no one is equipped to deal with it, nor are they able to innovate or do research because it is not the priority of a general hospital. Government had to prove and had the burden to prove why their specialized units are going to be capacitated to deal with anything that is specialized in the first place, to the extent that they were willing to trade this off coming from KL. At no point do they prove this, they just rely on an assumption. But more importantly, if it is truly expensive, then I question the quality or the extent of care that they're able to provide. They simply cannot. They say that, oh, general hospitals will have specialty units and this is sufficient to deal with it. But I'd like to question this because there needs to be a trade-off on government. If special care is as expensive as they say, then clearly quality and equipment are going to be severely limited on their side. If Riva's grandparent gets to go to a general hospital to look for specialized care, the most that you can get is a diagnosis, which inevitably leads to death, unfortunately, because they don't get care in the first place. They don't prove why these specialized units are going to be capacitated. I don't think they're able to co-opt this. At most, they can say that they get diagnosis, and there's maybe going to be one specialty. There's going to be one specialist for us in the first place. The implication for this is simple. You cannot get specialty care on government. They don't prove it beyond an assumption. What did they fail to respond to on our side? Firstly, they failed to respond to the RISE analysis from Lorraine. The most Riva says is, oh, these things are massively expensive. You're going to have to take a trade-off. Note that this was done over time. It's not like they just took all the doctors from a general hospital and plugged them all into a specialist center. I think it happened over time. Medical professionals came in over time. There were a lot of students that were medical professionals in the first place, which meant that they weren't necessarily taking away from general hospitals. Secondarily, this analysis means that the specialty care was then able to be better capacitated over time with the analysis that more of them came to rise over time, necessarily meaning that the prices fell and the accessibility increased on the comparative. But also notably, the exclusive thing that we're able to prove to you on our side is that we're able to cater these people on a greater degree. Why? First, Duca proves to you first through leapfrogging that we're able to get access to technologies that we weren't able to get in the past. Second, the economies of scale, because you're able to use these technologies over 10 years, over a lot of time. Therefore, I mean that we're able to cater to special care to a higher degree now because you had more modern technologies that were catering to these specialized illnesses in the first place, which is an exclusive benefit that you only get on our side because you capacitated the special sector to be able to treat these illnesses in the first place. Why is this necessarily important, which is unresponded to coming from Haduka? Notably, he said that these specialized illnesses are going to be massively important at the point in which you leave them unchecked, because this is the point at which it can turn into a pandemic. At no point do they respond to this coming from government. They have to then concede to this harm. And notably, this becomes far worse than things like tuberculosis or whatever disease that they want to cater to on their side, because this is where the diseases become far more fatal, but also become far more viral, therefore infecting far more people on scale. So if the problem on their side is tuberculosis, I'm quite unsure as to why we can't cater this on our side in the first place. I think general hospitals still exist, but this is where I'm going to deal with that problem in the first place, right? Is general care enough as it is? Because I want to note, the info slide is very clear. Specialist centers primarily deal with special cases, but it's not exclusively just special cases. So if I have tuberculosis, I can go to the lung center and get checked up. Still, if I don't have tuberculosis and I have some other sickness like pneumonia, I can still go to the lung center because a medical professional is still capable of dealing with my general sickness. Specialist centers are still capacitated to deal with general illnesses because you learn this in medical school regardless, notably meaning that on either side, the capacity to deal with general illnesses is symmetric because even specialist centers can still deal with this. At no point do they even try to deal with this coming from government. The info slide clearly says that they don't have to exclusively deal with special illnesses in the first place. We can deal with these general illnesses. What then the exclusive benefit is on our side is we can deal with these specialized illnesses on top of the general illnesses. On their side, maybe they have far more general hospitals, and maybe that's great because they can cater to more people on scale. But note that this isn't exclusive at the point in which even specialist centers can cater to these problems in the first place. Therefore, meaning that this problem that they're trying to problematize so much is not that big. The benefit isn't exclusive. We're able to co-opt it. The exclusive benefit we get on our side is threefold. First, you cater to the most pressing and urgent matter, which is the severe illnesses, which you only exclusively get on opposition. Secondarily, you're able to prevent massive outbreaks, which could kill the entire country, especially in a developing context, because they don't have the capacity to fend off against these things. You're only able to do it on our side. Third, in terms of innovation and research, you're better capacitated to research these things because you have centers dedicated to it in specific. So if it is a new disease, if it is a new problem, at no point do you deal with this in a general hospital on fucking government government, you can only get it on opposition. Therefore, meaning that the clear margin in this debate is that we're able to cater to specialized illnesses on top of the general illnesses. Maybe we have less general hospitals, but that's perfectly fine with us. But sure, let's take the trade-off and deal with the most uncharitable case coming from government, where it's only one specialty centers. Then great, innovation becomes far better off. You know why? You know why research is far better off? Because all the professionals, all the smartest people are centralized in one area. So if there's a Avengers level threat of a disease that comes up, then we are best capacitated to deal with it because all of them are in one area to study this. We're able to prevent the biggest outbreaks, and this is notably the most important, especially in developing countries, because a single disease that could go widespread could end our economy for months to come or for years to come. What's your POI?
So if, for example, I have a rare autoimmune disease, but it also has the same symptoms as tuberculosis, I can still go to the general hospital and still get it diagnosed. And there will still be a specialist that will have to treat to me because that's often required, especially when you don't have a specialist hospital taking all of the specialists away.
You're going to get treated for tuberculosis, but your disease won't be treated. So you die. I'm quite unsure why that's good. Like, clearly, nothing changes. I want to then deal with this on a general piece of weighing, right? Where are you better off then as a developing country? And note that this is important because of the debate about this developing country. We've clearly proved to you as to why we ought to prioritize these specialized sicknesses for the main reason that these are the most pervasive in developing countries. At no point do they prove why we ought to prioritize the average tuberculosis case, especially when we can still deal with it on our side. They don't prove any exclusivity on their side. Therefore, meaning that at least we get some margin of change on our side versus on their side, maybe you incentivize more people to go to hospitals. But notably, this is where Lorraine's extension clearly comes in and takes down their point. Because people are only incentivized to go to hospitals at the point in which it is dire, which means that at no point are you able to treat these people. And given that this is historical, you can't buy the positive incentive analysis coming from Zen because this is a retrospective debate. They had to prove why this was likely, especially within the context of a developing country, which notably they were unable to do. What then happens is on either side, people are only likely to go to hospitals or specialty centers at the point in which things are already dire, which means that the problem you are dealing with is specialized in the first place. Who is best equipped to then deal with this? Clearly, it is opposition. We win this debate on several key metrics. Firstly, on where we're able to deal with the biggest and most pressing problems of the developing country. Clearly, it is only on opposition when you have specialty centers, and the rise is directly where you're able to cater to these best by decreasing its prices, but also making it far more available. Secondarily, when you're able to deal with general care enough, because on our side, specialty centers can still do this. And third, and most importantly, even in our worst case, where you take doctors away, it still creates good things for the country because you are centralizing all the country's experts. For all of these reasons, oppose.
Thank you for that speech. Calling on op reply. Here, here.
Hi. Oh, I'm mute. Can I confirm if I'm audible through you, the people?
Audible and visible.
Okay, maraming salamat. Simulan na natin ang palastasan ng taon. I would extend my thank you coming from Lorraine's speech to Toby's dad because I think that government creates the wrong premise. They say that Toby's dad is the only bone doctor in Baguio and in the country perhaps. That's true. He is very popular there. But it's very wrong for them to say that they hope that he was a general doctor. I think in fact opposition would stand that we would have hope to have more Toby's dads in the world because people who had bone cancer, for example in Baguio, maybe had to only juice Toby's dad once. But if there are 10 people, then perhaps Toby's dad could not handle all of them. The rice would provide more Toby's dads in this world, and that is what opposition stands for. First path to victory. Who is truly more important? Government says it's the general public. We need to be able to help them. The first thing I'd like to say is look at the info slide. The info slide says that specialized centers are specialized but not exclusive towards just the specialization, which means that to some extent, opposition also has capacity to be able to help these people on the ground if they say that these people weren't able to access it. Like, not exclusive probably means that they're also able to access general care, the things that government was asking for. But number two, the fact that general hospitals already exist. And number three, that general illnesses already have generally accessible solutions already. When you can buy this off of the pharmacy and buy it off of your family doctor means that these are things that are not urgent because there are alternatives. What don't we have alternatives to? We don't have alternatives to the types of heart centers in the Philippines because there's only one. We hope that the rise was good good because there would be two, and that's a good thing. But also, number three, we think that diseases and problems we don't even know about could extend a massive harm, could be the next pandemic. So on two metrics, we tell you who's the most important. It is the severity of the harms. Even if there's like 5 people who have bone cancer, the fact that these people have a certainty of death under government side but have a lower certainty of death under our side is a win. But number two, on the scale of harm, note that there are diseases that exist right now could literally end the world, and the opposite government says nothing about it, by the way, which means that the urgency is won on opposition. Second path to victory, will it be gatekept? And this is government's main push. So the harm coming from government is like, malayo, and KL says this. And then Riva says, funding goes from general hospitals, so people will die. I just want to note how absurd this is, and I just want to make the joke again that you need to be a pole vaulter to jump to that conclusion, like to be able to jump to that conclusion. You need to step in as the judge to be able to buy this. Why? General centers already have the tools, like for the simple fact that they already bought them like 5-10 years ago, which means that it's probably fine. Like obviously the rise didn't cause like stupidity in the world for people to suddenly turn off all general centers. We think that at the very least some base level capacity to maintain them exists. But also I just like to note how absurd it is. Like we're not removing people's healthcare or life support just to plug it into another socket for the next healthcare center that's specialized. That's just crazy. But number two, the rise is actually good because we told you when there is an incentive to rise, that is when it is nearer. That is when it is cheaper. But let's be charitable. Let's say yes, it will be gatekept. Why is this a good thing? The fact that 0 to 1 is still a rise, and the fact that at the very least, the 10 grandmothers that is related to me could probably get all of this healthcare means that that's 10 grandmothers saved, and under government, 0 grandmothers saved. Last thing, what is left standing? Under opposition side, note that, sure, if you're unsure about everything's deadlocked, that's fine. Ateneo made it very messy. But what we are sure of, regardless, is people who don't know about diseases that will exist in the future need the type of focus and innovation that exists within these specialized centers. That is, regardless of whose grandmother is dying, the fact that everybody is affected by COVID means that these widespread things, if it was prevented, could have been the tipping point for us to be able to save a lot more people, to be able to save the economy. This is by far the largest impact under opposition bench, which by the way had no response from government. KL said, we can detect it. Sure, but you don't have the capacity or the capacity to prevent it. You can only detect it, and we think that's not enough. The only solution is to provide the specialized type of treatment that these people need right now, because it might be the only solution to prevent the next pandemic. Proud to oppose.
Thank you for that speech calling on government reply. Hear, hear.
Three, two, one. If the incentive for more medical students to specialize in specialized treatments are the rise of specialized centers, then an increase in supply of heart doctors does not spread throughout the country to help the most vulnerable, because what they were promised was a posh job in a nice urban center, in a nice specialized center within an urban hub. Even if you increase the amount of specialty centers on side negative, you don't spread accessibility, because specialty centers have to be close to urban hubs to be effective and have clients, or close to places with lots of individuals. Which is why you have specialty centers in big places like Manila, Cebu, or Davao, as we illustrated earlier. This means that their debate-winning argument of competition is untrue, because maybe at best you get an increase in specialty centers in urban hubs, as we preempted from first, but they barely respond to from DLO. So on the first metric of accessibility, they're already losing, even in their best case. But on our worst case, and they call us out, that we can't treat people, we gave you 3 mechanisms repeated down the bench that they never respond to, that were very, very crucial. And these were increasing in charitability all throughout my speeches, or our speeches. Firstly, we told you that we focus on prevention, which is likely and is important in a developing context, because before you get cancer, before you get osteoporosis, before you need heart bypass surgery, oftentimes it comes in small doses, like you getting sick every once in a while, you getting pneumonia, or you not taking your vitamins. Second level of charity, we told you that fine, maybe you weren't able to get prevention, at least you spread out pollen. Why is spreading out talent good? Because you get better chance for detection. If both sides rely on detection as a primary mechanism to prevent pandemics, then no amount of innovation will ever start without the prerequisite of detection. We get more detection in terms of weighing because we have more talent spread throughout and are not promised or are not just hedging their bets on going to a specialized center like they promised from all three speakers on negative. Lastly, we told you why accountability is much better because now general hospitals have an incentive to help you and not just offshore you towards a specialized center. This again helps the most vulnerable individuals, given that oftentimes not everyone has the luxury of resources and money like Haduka's grandmother to be able to go down to the mountain and get treatment. What this already suggests from this first flashpoint is that in terms of the solvency of our model, we are just more likely to be able to help individuals, even in the cases where even in our worst cases, as they suggest from negative. Second, on their claims of non-exclusive treatment, because they say, they can also have some treatment which is not related to the specialized disease. I agree. But the important delta here is that they don't say why it's good if a huge amount of individuals flock towards those specialty centers just to get general treatment. And here's where I want to point out, because they're banking their benefit on lots of people being able to get good treatment because they will spread out specialized centers all throughout the country. That means that these specialized centers over time become general hospitals or are necessarily able to provide the services of general hospitals. That means a couple of things. Firstly, general hospitals get worse as a result of more funding towards specialized centers. But second, this also means that they also contribute towards overcrowding on their side, because now everyone is incentivized to go to a specialized center on their side. They contribute to the problem that they want to solve on their side, as they pointed out. Lastly, on innovation, we also told you that R&D is better, because when you have specialized in in a general hospital in a far-flung region, they get a better diagnosis of the problem and have a chance to solve it. Obviously, we won't suggest that we cure every disease, even if it's novel, but at least we get early detection to defeat mutations like COVID mutations, like H1 and N1 mutations, or like polio mutations, which already happened to us in our country. So DLO is correct. People have hesitancy because of work, for example. They are hesitant right now to go to a hospital to take a leave because they fear that they do not get any solvency by talking to any doctors, by talking to any people, because there are no specialists right now. The mere presence of a specialist in a far-flung hospital bridges that gap and provides the hope for individuals to want to be able to go to that hospital, to seek treatment to begin with, to allow us to have early detection before it's too late. There are 3 tipping points here for us as to why we win. Firstly, because we fulfill the most proximate need for individuals for some level of access, which is better than a baseline or basically impossible access on their side of negative. Second, we're able to spread talent much more, which is also their win condition. We do this better on our side. Lastly, we get to do real innovation and real R&D.
Thank you for that round. You may now virtually cross the house. Cool. See you at the announcement. I'd like to tell my panelists to just stay here while everyone else hops off. Thanks.
Thanks for the debate,
Thank
guys.
you.
Thank you for that debate. Maraming salamat.